Assalamu alaikum, everyone. It's an absolute pleasure to welcome you all again for the second session of pediatric rheumatology course. Thank you very much for all the attendees who joined us for the first session. I must say it was overwhelming experience for us, me and Dr. Kamran, that there were so many people who were interested to learn about pediatric rheumatology. And of course, it helped us as well and my team to learn the basics, and of course the discussions around this that we'll be learning more in next 6 months time. I think I've shared the agenda as well already. So there will be two sessions today. First would be from Dr. Kamran about the GIA subtypes. He will be discussing excluding spondyloarthritis, which we'll be discussing hopefully in next session. The second session would be from our pediatric rheumatologist. We are all looking forward to both of these sessions, and the radiology session, of course, is a very different one. At least I have not been exposed to from learning from a pediatric radiologist, I must say. So I really look forward to have that session. So most of us know Dr. Kamran already. So I'll just give a little bit of introduction anyway. Dr. Kamran Mahmood is a very well-known consultant pediatric and adolescent rheumatologist at Elder Hay Children's Hospital, Liverpool in UK. He's also a college tutor at Royal College of Pediatricians and Child Health in UK. He's also an instructor for various different courses, the resuscitation courses and so on. He holds CCT Pediatric Rheumatology certificate from UK. He's also a fellow of Royal College of Physicians and Child Health, and also holds MRC. I think we all know him very well, and we are absolutely thankful and really grateful for his commitment that he has been helping us to learn about this whole field of pediatric rheumatology. And I'm sure all of us agree that he has been a great source for all of us. So without any delay, I'm asking Dr. Kamran Mahmood for his session to start, please. Thank you, Dr. Kamran.
Thank you very much, Dr. Haroon, for the very nice introduction. Can everyone hear me? Just the Zoom MBBS host can reply with yes.
Yes, we can hear you.
Yes, it's we can hear you, but if you can increase the volume, so it will be much better.
Does the volume increases from my side or from the, because my laptop volume is 100%.
Dr. Kamran, that's okay. Please proceed.
I think with headphones, it's completely fine.
Okay, so let me just share my slides. Okay. So only one person to reply if they can see my slides.
Yes, they are clear.
Okay, very good. Right, so I think most of you have attended our first lecture. So first of all, I'm really grateful all of you who joined this forum and participated and gave us very nice feedback from last time, and I hope that we'll get the feedback again this time. And special thanks to Dr. Haroon, who and engaged with me and tirelessly working in the background. I came back from Pakistan last time. Dr. Haroon has been in touch with me every week to get things ready for next lecture. So I think without his input and effort, this wouldn't have been possible. I also know that today is Sunday and everybody wants to relax, and I'm really looking forward to Lahore Qalandar and Multan Sultan final match of PSL. So I would do finish it before the match starts. So you all know that I work in Alder Hey Children's Hospital. So today we're going to discuss GIA management. So we already discussed systemic GIA in our last talk, and we will hope discuss other types of GIA today, some diagnosis, but we will exclude psoriatic arthritis, enthesitis related arthritis, because I think they need a presentation on its own. It would be very challenging to include all the subtypes in one go. So again, I have no conflict of interest. There's no funding for my slides, and slides are work from everybody from my team. We're going to talk about GIA and stepwise treatment, advanced treatment options. We'll talk about surgical options, BMT, and futuristic options. So usually a typical referral to the rheumatology outpatient would be something like, please see this such and such girl with a few months, maybe have some swollen joints, maybe some systemic symptoms of Raynaud's. And sometimes if we get referral from more enthusiastic pediatricians or GPs, they already do the antibodies, and antibodies come back positive, and then that becomes a source of referral as well. Sometimes referral is based on joint pains and arthritis, but usually the question asked is that could this be inflammatory arthritis? Now, when we receive, when any of us receive a referral for possible arthritis, these are the conditions that we need to exclude. So you will hopefully see in almost every presentation. So by the end of 6 months, you will all remember all the different types, differential diagnosis of arthritis. So you can see that there's so many types, so many other conditions to exclude before we make a diagnosis of GIA. So just because somebody has joint pain, it doesn't necessarily mean that they have inflammatory arthritis, and that's why we don't diagnose inflammatory arthritis in first appointment. Usually it takes a few weeks, and the diagnostic criteria is that the joint has to be there for 6 weeks, and that 6 week is required to exclude all these possibilities. So again, this is probably a repetition slide, but you will probably see this slide in every presentation, because this slide is the main message that I want everybody to remember. That juvenile idiopathic arthritis begins before 16th birthday. It has no known etiology, although we do have some theories, and it is characterized by the inflammation of the joint, not the inflammation of muscle, inflammation of skin, not the inflammation of bone. And symptoms have to persist for at least 6 weeks, as well as other known conditions that we looked at from the last slide to be excluded. People still call it juvenile rheumatoid arthritis, chronic arthritis, still disease, but unfortunately it's not. Just another reminder that it is a diagnosis of exclusion. So those of you who attended my first session will probably remember that we are moving away from ILR classification, but at the moment, while we still don't have any consensus, this is the best classification that we have. Systemic GIA, oligo-GIA, polyrheumatoid factor positive, polyrheumatoid factor negative, psoriatic enthesitis related, and undifferentiated. So today we will discuss oligo-GIA, polyrheumatoid factor positive, and polyrheumatoid factor negative, as well as undifferentiated types of arthritis. We already discussed systemic and spondyloarthropathy. Arthropathy, we'll discuss it next time. So by definition, oligoarthritis is when a child has inflammation in 4 or less joints. Within 6 months, if the arthritis progress and they develop more than 4 joints, then we don't change the diagnosis to poly-GIA. We call it extended. If a child presents with inflammation in more than 5 or more joints, then we call it polyrheumatoid, depending upon polyarticular GIA, and depending upon whether they are rheumatoid factor positive or negative, the subtypes are RF positive and negative. and then obviously undifferentiated types of arthritis, which are usually associated with the inflammatory conditions such as inflammatory bowel disease. Cystic fibrosis is well known to cause oligoarthritis. Celiac disease is also known to have association with inflammatory arthritis, and chronic non-bacterial osteomyelitis, typically in teenagers, presents with arthritis as well. And now the most common subtype is oligoarthritis, which is almost half. Most common age to present is under 5 years of age, and there is significant female preponderance. So this is a type of arthritis which is unique to pediatrics. This is not something that you will see in adults. While rheumatoid factor positive and negative, and there's the second most common subtype if you combine them together. However, the younger subtype, 2 to 4 years of age, has more, and 6 to 12 years of age, has again is more common in pediatrics. The older subtype, adolescent subtype, which is usually rheumatoid factor positive, is less common. It's only 2 to 7%, and it is very much similar to adult inflammatory arthritis or seropositive rheumatoid arthritis. Again, female undifferentiated arthritis accounts for 1/5 of the arthritis population. So oligoarthritis, usually 1 or 2 joints, but sometimes you can have 3 or 4 joints, and depending upon if you have both knees and both ankles. So in this picture, you can see inflamed knee, inflamed ankles, and the swelling of the knee. Systemic onset GI we discussed last time in detail, but again, you can see that they can present with arthritis, typical rash, hepatosplenomegaly, and typical pattern of fever. Polyarthritis, more than 5 and more joints involved, and you can see the number of interphalangeal, metacarpophalangeal, and radioulnar joints are involved in both hands. X-rays are not a useful investigation, but the only reason we had X-ray here that you can see that because of arthritis, carpal, what we call carpal clouding. So the carpal bones are very narrowed to each other. There's not much joint space between the carpal bones. Psoriatic arthritis typically presents with dactylitis, typical rash, and nail fold changes. Enthesitis-related arthritis, which we'll discuss next time, typically presents with enthesis, inflamed eyes, and usually involve Achilles tendon. So diagnosis of JIA is very much a clinical diagnosis, and there aren't any investigation which we call as pathogenomic for JIA. So clinical history is very important. Usually in JIA, there is early morning stiffness. Pain usually follows after a period of rest. There's usually joint swelling, and there are other features such as bowel, systemic involvement, and family history is quite important, such as history of inflammatory arthritis, or psoriasis, or other autoimmune conditions such as autoimmune thyroiditis, celiac disease, type 1 diabetes. Bloods is not diagnostic part of diagnostic criteria, but they can help sometime to classify, such as factor HLA-B27, and to define and provide the prognosis. Inflammatory markers, including the blood counts, can be normal. X-rays are not a helpful investigation in pediatric inflammatory arthritis, because by the time you see changes in X-rays, it's already very late. So we do X-rays to look for any signs of damage or exclude other causes, dysplasias or metabolic disorders. Ultrasound and MRI are the most useful radiological investigations when it comes to GIA. So coming to investigations. Bloods, as I mentioned, inflammatory markers, blood counts, and autoantibodies, they can be normal or abnormal. Autoantibodies can be positive or negative. On its own, it doesn't include or exclude a type of arthritis, so it needs to be a combination. So we will explore these investigations one by one, how we can relate the investigation results with our clinical findings to make the diagnosis of arthritis. Let's start with ANA. So let's say you see a 6-year-old girl with pain in knees and bloods are taken for rheumatology screen. And as part of screen, the child has ANA done. There are many possibilities for ANAs. It can come back positive or it can come back negative. Within positive, it can have different levels of titers. So for example, if you have 80, does that mean anything versus 1:60 versus 1:40? So the higher the titer ratio, so it becomes a bit more sensitive and more meaningful. So for example, 1:160 would be more strongly positive compared to 1:80. The problem with rheumatological bloods, especially with autoantibodies, that these can be positive at low dilution, and ANA notoriously can be falsely positive, as well as it can be positive up to 30 to 40% of normal healthy pediatric population. It can be following infections. So we know that children will frequently get sore throats and tummy infections. So we need to consider when we are interpreting these results, and always make sure that we repeat them again if there's any ambiguity at the timing of the investigation. If it's of rheumatic disease, then no matter they are ANA positive or negative, they need evaluation to make clinical judgment. ANA is not a good test and is not accurate enough to answer these questions, whether a child with rash and fever have lupus, or whether the child with swollen knee have JIA, or whether this child is going to develop uveitis. So ANA can be positive in 97% of children with SLE, but not everyone who is ANA positive will have lupus. So those who have diagnosed lupus, those 97% of children lupus positive. Dear host, can we please mute everyone? 60 to 70, ANA can be positive in 60 to 70% of dermatomyositis patients. Again, it's within the population of dermatomyositis. So those with rash and muscle inflammation, ANA positivity is very useful, but on its own, it doesn't mean much. It can be positive up to 2/3 of localized scleroderma and 80% of systemic sclerosis patients. It can be positive up to 80% of GIA patients with uveitis, but young children can get uveitis even if they are active. It's rarely positive in vasculitis and other autoimmune diseases. However, it can be positive, especially with autoimmune liver condition, pericarditis. It's a useful investigation to help defining primary and secondary ANAs. And it's also very, very important to reiterate the fact that ANA can become positive following infection. It is usually positive in patients who have malignancy. It can be positive from drug reactions and can be positive from environmental toxins. So the important thing, again, relate ANA positivity with the clinical finding. And again, low titers are usually not that significant. It can be because of so many other things that I've just explained. So usually we take titers more than 1:120 as significant. When is ANA useful? Useful if when we are defining patients who have Raynaud's. So if a child has Raynaud's and they are ANA negative and nail fold capillaries are normal, then they're likely to have primary. Primary means that it's not linked with underlying connective tissue disorder. However, if they have ANA positive and nail fold capillaries are abnormal, then there should be strong of systemic sclerosis. ANA positivity in idiopathic thrombocytopenic purpura can be a predictive factor for evolution to systemic lupus erythematosus. In uveitis, ANA positivity is a risk predictive factor, which is statistically quite important. However, clinically, sometimes it doesn't correlate with the findings. In GIA, it's usually negative in systemic GIA, and those who have positive ANA, especially with rheumatoid factor positive, it usually represents the worst prognosis. Patients on biologic they are usually at risk of lupus because of immune modulation from the biologic. So we usually check their other autoantibodies at least once a year. And frequently we find the patients can become ANA positive while they're on biologics. When we are interpreting results of autoantibodies, we need to keep in mind that anyone who has been treated with immunoglobulins for any reason will have autoantibody positivity up to from the donor immunoglobulin. So please keep that in mind. The second commonly autoantibody done in patients with concerns about arthritis is rheumatoid factor. So rheumatoid factor can be positive in about 3% of polyonset GIA. The results of registry, there are increasing chances of rheumatoid factor positivity, so it's commonly positive in teenagers and rarely positive in younger patients, and especially under 5. It can also be positive in both in primary Sjogren's and secondary Sjogren's as well. Again, just like ANA, it can be following infections. Sometimes it can be positive due to genetic reason because it shares the epitope with HLA-DRB1 antigens, and it can become positive in lupus as well due to secondary Sjogren's. The next most common autoantibody tested in patients with inflammatory arthritis, especially with back pain, is HLA-B27. So absolutely no need to keep rechecking HLA-B27 because it's a genetic test. Once it's positive, it will never become negative. So once a child is HLA-B27 positive, then you don't need to check it again. Associated with increased risk of ankylosing spondylitis in male children, especially in those who have family history of ankylosing spondylitis, much lower in female children. Children who have ascites-related arthritis, 90% of these children are usually HLA-B27 positive. So again, it's in the subcategory of ERA, HLA-B27 negativity. It doesn't exclude the diagnosis, so it's important to make sure that we relate these findings with the clinical picture. Almost everyone with the concerns about inflammatory arthritis gets their ESR and CRP checked. So these CRP and ESR are likely to be abnormal in systemic GIA, and they're usually associated with lymphocytosis as with if a child has normal platelet in a setting of systemic GIA and they have high ESR and CRP, then please consider bone marrow because it may be normal platelet may well be because of leukemia, or and ratio wise they may be lower than normal. In poly-GIA, we usually expect raised inflammatory markers depending upon how many joints are involved and how long child has had disease before treatment. Typically, ESR can be quite high in ascites-related arthritis, especially when it's associated with inflammatory bowel disease, but it can also be normal. Should almost always be normal in oligoarticular GIA. So if a child has high platelet count, high CRP and high ESR, think of other causes. If they only have one inflamed joint, then think about other causes such as infection or malignancy. ESR and CRP ratios can be quite useful. In lupus, usually ESR is quite high and CRP is relatively normal unless the patient has sinusitis or associated infection. So in a stable lupus patient, if ESR is normal and CRP is high, then always consider underlying infection. In HLH or MAS patients are usually drops relative to CRP. So you have high CRP and lowish, high but lowish ESR compared to CRP levels. So clinical condition and relating with other antibodies is very important, and other blood tests such as platelet count, hemoglobin, and white cell counts. So in summary, we expect systemic GIA to be slightly anemic, raised inflammatory markers and antibodies usually negative. In oligoarthritis, except ANA positivity, everything should be normal or negative. Rheumatoid factor negative poly-GIA can have slightly raised platelets and raised inflammatory markers and can be ANA positive or negative. And because they are rheumatoid negative poly-GIA, so by definition, they should be rheumatoid factor negative. Rheumatoid factor positive usually have raised inflammatory markers, raised platelet counts, and can be ANA positive or negative. Psoriatic patients usually are B27 positive, sometimes ANA positive. And because of a combination of inflamed joint and skin, their inflammatory markers are usually high, as well as platelet counts. And then related arthritis are axial arthropathy, and inflammatory markers are usually high. And as we discussed earlier, HLA B27 is positive in almost all these patients. Now, once we made a diagnosis of GIA, next step is obviously treatment of GIA. So treatment goal for any disease should be to get patients into remission as soon as possible with aggressive treatment, and then keep them on maintenance treatment for symptomatic improvement, and prevent the damage from disease in long term, so the child can achieve normal growth and development. Another marker of success of treatment should be that after the period we should be able to wean off, because if your child is well on long-standing treatment, then it's not really a success, because in long term patients should be able to come off, get into remission and come off treatment. Always aim for normal growth and development. Children should be, treatment aim should be to get children into normal schooling, normal adolescence, normal childhood and young adulthood, and also to recognize and damage from uveitis. So for treatment for oligo-GIA, it's relatively straightforward. We do intra-articular steroid joint injection. In UK, most of the Europe and Western world, we use triamcinolone hexacetonide. And it depends on the body weight, but we never use more than 40 milligram of triamcinolone in one injection, and we never use more than 20 milligram in smaller joints. So up to 40 milligram for bigger joints such as hip, knees, shoulders, and rest of the joints is a maximum of 20 milligram. When it comes to toes and fingers, it's usually only 1 to 2 milligram. If the patient's 6-week period, then it's better not to do joint injection, but give them non-steroidal anti-inflammatory medication and review them after 6 weeks for the need of injection. And all these patients require uveitis screening. For poly-GIA patients, whether they are rheumatoid factor positive or negative, the first line of treatment is systemic steroids, with 3 days of intravenous methylpred, usually after with a gap of 1 week. Another pulse, so 2 pulses of intravenous steroids lasting for 3 days, and then reassess to see whether they need further steroids, weaning course of oral steroids, or joint injection. The dose of intravenous steroids is 30 milligram per kilogram, with a maximum dose of 1 gram. And then usually we wean off steroids over 6-week period and start them on systemic DMARDs, which is methotrexate, 15 milligram per meter square, with a maximum 25 milligram. The 6-week weaning of steroid gives a chance to methotrexate to start working in, and then we usually review them at that time. We tend not to inject more than 5 joints in children in one go. So the aim, the reason for giving them intravenous steroids is to try to get their joint counts below at or below 5 by systemic treatment. However, once they had courses of steroids and methotrexate established, then any residual inflammation in the joints should be treated with intra-articular steroid injection. So methotrexate is a little bit about methotrexate. So it's very cheap. profile is very good in children. Rheumatology patients use a relatively small dose. It's available both oral, subcutaneous, and intravenous. I think almost all patients in Pakistan should be able to afford methotrexate. It's an antifolate medication, so when you start somebody on methotrexate, you prescribe them folic acid as well, but advise them to take it on any day except the methotrexate day. In patients who develop symptoms of nausea and vomiting, you can increase the dose of folic up to 6 days a week, exclude the day of methotrexate. Methotrexate is once weekly dose. Failure of methotrexate is defined by no remission within first 3 months, or patient unable to continue with methotrexate due to significant side effects. Level 2 treatment is biologic treatment. It's since the early 1990s, biologics has been used and it has transformed the care of pediatric population. Now, in modern JIA cohorts, as you can see from the study, more than 95% of children achieve clinically inactive disease. However, out of those who achieve clinically inactive disease, half of them usually require biologics to attain clinically inactive disease. So do not hesitate to start a child on biologic treatment, but at the same time, we have to give chance with, we have to treat them with steroids and methotrexate, because not every child needs biologic to get, not every child responds biologic to get better. Those who respond to biologics usually respond a lot better when treatment is given in combination of methotrexate and biologic. So these are different types of biologic. Biologics usually work by blocking certain lymphokines and cytokines. So you can see from this picture that different biologics block different interleukin receptors or receptors, and that therefore they desired results by blocking the inflammatory cascade. The most commonly used biologics are anti-TNF, which is either a monoclonal antibody such as infliximab, adalimumab, satralizumab, or golimumab, or with a circulating receptor fusion protein or chimeric protein such as etanercept. Infliximab is not used. However, we still use infliximab in complicated patients who don't respond to other biologics, especially in unresponsive uveitis as well. Most commonly used biologic as a first line is etanercept. We started as a subcutaneous dose twice. And once children achieve remission, then we changed once weekly dose. Twice weekly dose is 0.5 milligram per kilogram per dose, and once weekly is 0.8 milligram per kilogram per dose. Maximum dose per week is 50 milligram. Adalimumab is subcutaneously fortnightly, less than 30 kilogram get 20 milligrams subcutaneous injection, and less than more than 30 kilogram get 40 milligrams subcutaneous injection. It's a first-line biologic treatment for GIA uveitis proven by Sycamore trial. Tocilizumab is second-line biologic for GIA patients and first-line biologic for systemic GIA patients. It's fully human IL-6 receptor MCA. We try not to use tocilizumab in the last 3 years, and due to increased demand of tocilizumab in COVID hyperinflammatory patients. However, we still use it for patients who don't respond to first and second line biologics. And the dose of tocilizumab in children is 8 milligram per kilogram 30 kilo and 12 milligram per kilogram for less than 30 kilo. It can be given both via IV infusion or subcut. There is another IL-6 blocker, sarilumab, which has just completed trials in pediatric population and is now available for clinical practice as well. Anakinra and canakinumab are IL-1 blocker. They are systemic onset GIA. However, in some studies, they have shown good effects both for inflammatory arthritis as well. Our third line biologics are abatacept and rituximab. Abatacept is selective T cell co-stimulatory modulator. We usually prescribe give a 4-week milligram per kilogram infusion. It's now available as a subcut preparation as well. Rituximab, we tend to use it as a last biologic It's an anti-CD20 monoclonal antibody. It has significant immune suppression effect. We use it as a last biologic, especially in rheumatoid factor positive poly-GIA. Patients on rituximab needs significant monitoring for their blood counts and infection screens, and they need they usually get a dose, one infusion on day 1 and second infusion on day 15, and subsequently depends on clinical response. Some patients don't require any further infusion. Then we have newer biologics, and sarilumab is anti-IL-6. It's current that I just mentioned before. Ustekinumab is commonly used in psoriatic arthritis and psoriasis in adults, and in pediatrics as well. We have started using it in pediatric psoriatic arthritis population as well. It inhibits differentiation of naive CD4 cells into T helper 1 or T helper 17 phenotype. So it blocks anti-IL-12 when it blocks IL-12 and IL-23 receptors. Secukinumab is anti-IL-17. It has been used successfully in adult population for psoriatic arthritis and axial arthropathy, and we have now concluded trials in UK for children, and now it will be very soon available for the use in psoriatic GIA and ascites-related arthritis. We have newer therapeutic agents, which is Janus kinase inhibitors. There are 4 members of JAK tyrosine kinase family: JAK1, 2, 3, and TYK2. JAK1 and 2 mediate signals of important cytokine targets in GIA. Interferons, IL-2, 6, 10, 12, and GMS-CSF. And JAK3 is primarily involved in signaling, maturation, and immune function. There's potential for less immunosuppression by sparing inhibition of JAK3, and this is a diagrammatic representation of how JAK kinase receptor blockers work. So the benefits of JAK kinase inhibitors that these are oral, and they provide strong. They're very good in blocking the inflammatory cascade, but they do not suppress the immune system significantly, such as rituximab. So they are in the adult trials have shown significant good results both in tofacitinib and baricitinib. So both tofa and bari are now commonly used in adult population, and tofacitinib has been used for the last couple of years in pediatric population, and baricitinib is currently in process of completing. Initial results of trials are very promising, and we hopefully be able to use baricitinib in pediatric population very soon. So biologics are very patients, they are safe, but they need to be given to right patient for right indications and with the right precautions. So all the patients who receive biologic, they need to have their blood counts, their vaccination status, and immunoglobulins checked before, as well as the TB status. And then they need regular blood counts every 3 months. As long as they are on steroids, they need to have their autoantibodies checked once every year. And they need to have a regular screening for TB as well. So as long as you can provide this type of monitoring, no harm in using biologics. And so you need to educate patients that these medications are serious medications, overdosing them or not monitoring them or missing the blood test poses with serious infections. So patients need to know when to have their blood test. They need to have diaries for their blood test, and they need to have number to contact medical professionals when children develop fever, to make sure that they are not they stop their biologics and take appropriate antibiotics. It is very important to define length of treatment. So when you start something, you should always think of the criteria of stopping. So we stop biologics between 3 to 6 months if we have no and switch to other biologic. and we usually start biologics soon after 2 years of complete remission. So if we start biologic and after 6 months child gets into remission, and then 24 months in complete remission, then at 2.5 years we stop biologic and then take it from there. The child then needs more rigorous surveillance to look for any resurgence. Biologics are relatively safe in long term, but we need to explain this to patients and also understand ourselves. The patients who require biologic are the patients who have aggressive disease. That's why we're treating them with biologic. So they already have inflammation in their body, therefore the immune modulation, resultant antibody production, and risk of malignancies such as lymphoma should be higher, because not because of treatment, but because of their presentation and inflammation. I don't think there's much reported for the cases of lymphoma, leukemia in patients in biologic, but it has been reported in patients who were treated with infliximab for inflammatory bowel disease. But again, inflammatory bowel disease itself has a significant association with development of lymphoma, and one think that those patients who were treated with infliximab were those who had high levels of inflammation in first instance anyway. In long-term, biologics are cost-effective because you are preventing long-term damage and therefore burden on the health system. And now with the advent of biosimilars, the cost has come down significantly, which makes me a little bit anxious as well, because now if they are more affordable and more achievable, then there's a tendency from mostly from patients, but sometimes from clinicians as well, to bypass the first and second level of treatment and just treat everything with the strongest possible treatment, which is a wrong approach. Those patients who fail to respond to all medical therapies still have possibility of surgical options such as joint replacements. It's almost unheard of for the child to get joint replacement in the last 20 years as treatments has advanced too much. However, there are still patients who have disease, and there are other technologies which are developed. In Alder Hey and many other parts of UK, we use this technique called arthrodiastasis. In this, surgically joint space has been gets created through the through a Lazarov frame, which helps children to achieve maturity, allow time for medication to work, relieve the symptoms of pain, and it also allows people to for newer medications to come into market and take effect as well. So this is an example of a patient who was treated with Lazarov. This is how Lazarov injection look like, and basically what it does, as you see the frame. So this is the X-ray of a patient before the frame. You can see that the joint space is almost gone, and the bone looks very unhealthy and damaged. With the Lazarov frame, it slowly increases the space, and now the joints look a little bit healthy a year down the line, and there's more joint space, and bone looks healthy as well. And so this helps young patients to have better skeletal maturity and grow in a relatively normal way, and helps them to have significantly less pain, and help them to work with their day-to-day activities. Bone marrow transplant in GIA is reserved for patients who have no improvement with at least 3 biologic treatments, and it is for patients with severe progressive disease and failure to respond. So bone marrow transplant stem cell studies in GIA has good outcomes, and we have a couple of patients in our unit who responded well to bone marrow transplant. But this is a very select group of patients, and this is a very highly specialist decision need to be made by a number of professionals involved, including rheumatologist, infectious disease, hematologist, oncologist. Family needs to be involved in all these decisions. So in conclusion, GIA and different types of GIA are clinical diagnosis. Investigations are there to help, and there are many treatment options available. Treatments are changing rapidly, and help is available through different networks. You just need to pick up a phone and either email or ring somebody about it and ask them for help, because at the end of the day, we all want to help the patients.
ठीक है. She reports intermittent pain in the tips of her fingers when exposed to cold.
Cold.
क्या है इसको?
Scleroderma.
SCL17 antibody
These are positive.
ये scleroderma
Can we stop talking?
gastric manifestation क्या होगी?
इसमें ये होता है कि esophageal dysmotility होती है. CREST
That's
syndrome है.
the-
CREST. Calcinosis, Raynaud's phenomena, esophageal dysmotility, as for sclerodactyly and T for telangiectasia, या CREST syndrome. ठीक है. और इसमें ये है कि स्किन टाइटनेस हो जाती है, फीमेल्स में होती है, मिडिल एज फीमेल्स में होती है, ब्लूइश डिस्कलरेशन होती है ऑफ द फिंगर्स ऑन एक्सपोजर टू कोल्ड आ जाता है. ठीक है.
Dysphagia.
Okay, I'm really sorry, whoever was having this very academic discussion, this is very inappropriate. So if you want to have discussion about your patients, you shouldn't be in this meeting. So that's the end of my talk. I think we should take questions in the end. So shall we, I'm going to share the presentation of Dr. Karen Landers. Could the host please tell me that everybody can still hear me?
Sir, we can hear you. We can hear you, sir.
Okay, thank you. So I will stop sharing my presentation. I will share the presentation of Dr. Karen Landers.
Excuse me, sir. Sir, this stabilization of joint which you have just shown about.
Can we take questions in the end?
Okay, sir. Okay. So can we ask the question right now?
No, can we take the questions after presentation, please?
Okay, sir. Okay.
Right. Can one participant please tell me if they can see this slide? Pediatric musculoskeletal radiology.
Yes, sir. We can see, sir.
Okay. So
Yes, sir,
let
we
me
can
just
see.
Let me just introduce. So Dr. Karen Landers is a consultant pediatric radiologist. She has more than 20 years of experience of pediatric radiology. Musculoskeletal radiology is her area of interest. She has been very, very, very kind to give her time to make these slides, and not only to make these slides, but also to record them and send it to us. She's currently in Iceland on holidays, and she couldn't join us, but she has shared her slides. She's one of the UK #1 MSK radiologist, and probably one of the top 5 in the world when it comes to radiology. So please pay attention to her talk. You will probably not find a person second to Karen Landers' ability. She's excellent. Those of you who are talking about different patients, please do not do this. I'm only doing this in my own time to help you. This is a complete disrespect to all of us who are doing this to help pediatricians in Pakistan. If you have patients to discuss,
Really thankful to Dr. Karen Landers, who is a pediatric consultant pediatric radiologist at the same Alder Hospital. So just a little bit brief introduction regarding Dr. Karen Landers. I have shared her a little bit of bio as well in our forum as well, but I'm just going to read it out a little bit about herself. So she has been a consultant radiologist at Alder Children NHS Trust since 2006. And she is also a clinical director for radiology services since 2012. Our expertise are quite wide as regards pediatric radiology, regarding the trauma as well, and so on. She also has a special interest in MSK radiology, and we're really thankful for Dr. Kamran to pursue her to teach us a little bit about MSK radiology in pediatrics, and of course with the background of the GIA, and she will be helping us to learn about this. So there will be the two things in her about 40 minutes discussion. Firstly is the differences in pediatric and adult MSK imaging, and the second one will be GIA through the eyes of a radiologist. So we're going to start her session now.
So we can't hear. You can't hear us, sir.
No voice.
So we cannot hear.
Can you hear me?
We can hear you, sir, but we
Yes,
couldn't
sir.
hear her.
Okay, just one person, please. Okay.
We can hear you, but we cannot hear her. We couldn't hear her, sir.
Yeah, give me a minute to restart it.
Okay, sir.
Good morning. My name's Karen Landis. I'm a consultant paediatric radiologist from Alder Hey Children's Hospital in the northwest of England in Liverpool. I'm delighted to be able to talk to you today on the imaging in pediatric musculoskeletal system. Pediatric MSK, well, what does it encompass? It's a huge spectrum of disorders, including trauma, infection, inflammation, malignancy, metabolic disease, and congenital pathologies. I'm not going to talk to you about trauma and malignancy today because that's a whole nother topic in itself, but I'm going to try and cover some pointers on imaging in infection, inflammation, metabolic diseases, and in identifying congenital disorders. Where do you even start? Well, it's really important.
Can everyone hear it?
It's important when
Yes, sir. Yes, sir. It's all right now.
Okay.
know what your radiologist is talking about, which part of the bone is relevant, and particularly when you're dealing with children, know how they differ to adults. The epiphysis is the part of the bone that is at the end of the bone closest to the joint. It is initially cartilaginous and it ossifies with age. So it gets more bony as the child gets older. The physis is the area between the epiphysis and the metaphysis. This is the growth plate, and this fuses at adulthood. The metaphysis is the area on the long bone side of the growth plate. This is a highly vascular area. This is the side of the bone where new bone is formed. This is the growing point of the bone. And the diaphysis is the shaft of the bone, the long part of the bone. And again, as I say, the radiologist will use these areas to define what they're talking about. From a clinical point of view, you need to know what they are in order to understand the report. The thing to bear in mind is that the physes can fracture and epiphyses can slip. So you might get a SUFI, a slipped upper femoral epiphysis. We also see at the elbow that the medial epicondyle might slip. As I say, I'm not going to touch on that in this talk because that's related to trauma, but it's just to understand where injuries can occur. You can see apophyses. These are growth centers that occur at the periphery of the bone and are adjacent to the bone with a growth plate. You can also get accessory ossification centers. These lie adjacent to the bone and will never fuse. They will also always be separate to the bone. You'll see in areas like the feet, particularly, you can get a number of accessory ossification centers. And it's important to recognize that these can be normal or are normal, and that they shouldn't be misinterpreted for bony fragments. How do we image pediatric MSK? Well, we're really lucky because we've got the whole gamut of modalities. I love X-ray. I think it's a really useful tool. It's a great way of investigating because it's quick and easy. Ultrasound is operator dependent, but is a great modality. We do use CT, and of course we like MR. Rarely we now use nuclear medicine, but it is available if it's required. So why do we like plain film? It's great for looking at bones. It's not so great for looking at the soft tissues and the internal architecture, but it is really readily available. It's quick. You don't really have to keep a child still for very long, but it does involve ionizing radiation. What about ultrasound? What do we use it for? Well, it's really lovely for looking at soft tissues, at the joints. It gives you with Doppler, it gives you an indication of vascularity within the soft tissues. It's not great at looking at the bones. You can see the margin of the bone, but you can't tell what's going on within the bone, and you can't see the internal architecture of the joint. It is quick. It is readily available. No radiation dose, which is great. You don't have to have a kid that is lying still. To be honest with you, if your kid, if you can follow the kid around the bed, that's great. You'll still get your imaging. It also means that your child could sit on mum's knee or dad's knee while they're being examined, but it is operator dependent, and it might look easy, but it's not. You do have to have the skills of ultrasound, and you do have to understand what is normal. CT is a great tool for looking at bony detail, but it involves high doses of ionizing radiation. And as I'm sure you're aware, in pediatrics, we do our best to avoid ionizing radiation where possible. So CT, we don't use like it's used in adults. It's rarely used, really. But it is available if you are worried about bony detail, if it's going to influence patient management, maybe surgical intervention. MR, of course, it's being increasingly used. It's very valuable. What is it good for? It's great for bone marrow, great for joints. You can see internal architecture, not brilliant for the margins of the bone, so not great for cortical bone. You can get all sorts of planes. It's not just one plane. You can go in it, it's multiplanar, and there's no radiation, which is fantastic for pediatrics. The difficulty with MR is that the scan times can be very long. They may require anesthesia, and they may involve intravenous contrast. So it can be invasive for some small children. We don't use sedation at Alder Hey. That's our practice. We use anesthesia or nothing. But some centres do use sedation, and again, that's perhaps reduces the risk of that you may have with general anesthesia. As I say, we don't tend to use nuclear medicine anymore. We did use it. It's really good for identifying abnormal bone turnover, but it might be very sensitive, but it's very non-specific, and it involves a high dose of ionizing radiation. So really in our practice, for imaging MSK, we have moved away from nuclear medicine, and we now predominantly use MRI. So let's look at some pathologies. We start with infection. I'm going to give you a case example. We've got a 17-month-old boy who cries when he's being fed. He's under the investigations of the gastroenterologist. His CRP is raised, and he's otherwise fit and well. Nothing so far from the gastro investigations have come back positive, and he had an abdofilm. Now, you've focused this down to his spine. The astute amongst you will notice that there is potential joint space narrowing, disc space narrowing, but actually when you do the lateral view, you can see it much more clearly. So there is something going on, doesn't quite have the nice defined margins of the other levels, but on that lateral view, you can see there's really an abnormal disc space with loss of vertebral body height, quite marked destruction of the end plates of the adjacent vertebra. And plain film is very useful in these cases. But of course, MR is really the diagnostic tool. We need to know what's going on here. How acute is this? Is there an associated soft tissue component? Is there a collection that needs draining? What's going on in the posterior compartment? Is the spinal canal involved? Is there compression of the cord or the nerve roots? So a fat suppressed T2 sequence is really useful in identifying pathology, marrow edema, soft tissue edema. If you get a T1 sequence, again, you can see marrow edema on a T1. T1 with gadolinium is the way to identify any evidence of an associated pre-vertebral collection. Who gets discitis? Well, it pretty much occurs in two peaks. So young, 6 months to 4 years, or in older children at sort of early teens, 10 to 14. Typically, it's a Staph aureus infection, and typically the lumbar spine. And we tend to investigate with multimodalities. You might not see the degree of destruction as we've seen on the plain film in this case. You might just start to see abnormal disc chain signal and adjacent end plate changes. So it's better seen on MRI. The interesting thing is that the example I've given is actually a case, it is not atypical. Children can present exactly like that. They're fine when they lie flat. The minute they sit up, it's uncomfortable. Children that go off their legs, want to be carried everywhere, don't want to walk, always consider discitis because it's one of those pathologies that is often missed. I've got a next case is a 4-year-old girl. She's presented with a single acutely painful swollen knee, and she's got a raised temperature and increased inflammatory markers. On examination, on X-ray, she's got what looks like a joint effusion. You can see here the suprapatellar pouch. You should see the nice fatty, low density of fat in the suprapatellar pouch, and that's lost. So she looks like she's got a joint effusion. And when she comes up for ultrasound, you need to make sure when you do ultrasound of a joint that you use the right probe on the right setting. That's really important. So in pediatric MSK, we would use a high resolution linear transducer. We would apply the right setting. So get your app specialist to come in and make sure that you've got the right MSK settings. So use a knee setting for a knee, use a shoulder setting for a shoulder, use superficial MSK for fingers and toes. So the right probe on the right setting. And it's really important that you know your anatomy. So have an understanding of what it is you're looking at. Do know your limitations. Ultrasound is a great way of having, have a go by all means, but understand when you need to ask for help. Make sure you know that what is an effusion, what is not an effusion, what is pathology, what is normal. And this is my bugbear, people who don't annotate their ultrasound images. So if you're going to do ultrasound, please annotate your images appropriately. Let me know when you send the images to me for review, what it is that you are looking at. What have you scanned? It's really important. If you send me an image with no annotation, I don't know what part of the body it is. And it's great from your own reference point of view when you go back. This is what I was looking at. This is what I was worried about. This is the area of abnormality. Much more useful here than an unannotated image that, weeks, months, years later, you don't know what it is you've reviewed. It's very important to know what's normal. And unossified cartilage is one of those things that does cause complication because it's that low eccentricity, but actually it's not typical of fluid because it has a very fine end within it. So this is unossified patella. This is unossified femoral epiphysis. Patella, this is femoral epiphysis. This is proximal tibial epiphysis, tibial tuberosity. That's patella tendon. We had a child that presented some time ago now that was referred from another hospital where the imaging had been, somebody had done an ultrasound and it had been reported as a pre-tibial collection. And the orthopod came to see me and said, before we take this child to theatre, can you just confirm what I'm looking at? And the area that they were worried about was, in fact, the unossified patella. There's no evidence of a collection. So really important to know what's normal and recognise what unossified cartilage looks like on ultrasound. What you might see is fluid in the suprapatellar pouch. This is an ossified patella. This is fluid. You can see quadriceps tendon here, bit of synovial thickening. In which case, you have to consider that this the causes of a joint effusion. In this child, we were worried about a septic arthritis. Who gets it? Small neonates and children. Bug depends on the age group. As you can see, if you're a neonate, you're more likely to have a septic arthritis or also a strep. But as you get a bit older, it's more likely to be a staph or a different strep pyogenes. Typically hip and knee, but can be anywhere. How do we investigate? Well, we investigate with ultrasound, but it's really important to recognize that just because there is joint effusion doesn't mean it is septic arthritis. It may be an inflammatory arthritis, and that's where clinical correlation comes in. But when it's a single joint, it is often difficult to differentiate. The other thing to bear in mind is that when you do ultrasound, you might find that actually the collection is outside the joint. You might have an abscess formation within the soft tissues. And again, it's just understanding the anatomy of the area that you're scanning. You know, this is anterior to the quadriceps tendon. This is anterior to the patella. This is a soft tissue collection. It's not in the joint. What about this child? She's a 12-year-old girl. She's had a 6-day history of a painful wrist, and mum said she fell over in the park. She came in, she got a normal full blood count, and of course she had a plain film. There's nothing on this that worried us, except she's really uncomfortable and complaining of a lot of pain. And you can see on the distal ulna. Go back to the brain. Show a permeative hypothesis, and over time, 4 weeks and then in 8 weeks, you can see the progressive change. This is treated. So you can see that she's got this permeative lucency that progresses with a bit of sclerosis and then starts to resolve and look more normal. What was this? This was osteomyelitis. This affects children of any age. And again, the bug is typically Staph aureus, but in neonates, you have to think about other bugs like group B strep and E. coli. It has a predilection for femoral, for affecting the femur, but can affect tibia, humerus, fibula, typically metaphyseal. And that comes back to what I was saying earlier, which is that the metaphysis is highly vascular. So hematogenous spread of infection gets to the metaphysis and causes infection. Neonates, they may have epiphyseal because of the transphyseal vessels. Don't exclude neonate baby that hematogenous spread has laid down infection in the epiphysis. How do we investigate osteomyelitis? X-ray and MRI. Ultrasound is not going to help you with osteomyelitis. If you're worried about it, get an MRI. And if you've got a child where you're worried about osteomyelitis, a plain film is not going to be enough, because the plain film changes or the radiographic changes of osteomyelitis occur late in the course of the disease. So you may have a normal plain film, but the child may have osteomyelitis. So if you've got clinical concern, then MRI is the way to go. What might you see? Well, acutely, you'll see possibly inflammatory bone changes. So you'll see marrow edema. You'll see maybe a bit of an associated soft tissue reaction, but you won't see the X-ray changes. As you move along, you'll start to see periosteal reaction on the X-ray, and then by the time you've established a chronic untreated osteomyelitis, you start to see bone destruction and changes within the changes on the plain film. So this is a child with, you can see the progression of osteomyelitis. There's an abnormal lucency within that distal metaphysis, the metaphysis of the metatarsal. There is some periosteal reaction over it. And you can see here it's more established, but there is some bone destruction within that center in association with chronic infection. The other sort of infection that we see is a Brodie's abscess, where you've got infection at the metaphysis that then grows to become part with it to lie within the bone. These can be indolent and they can be difficult to identify, non-specific pain. They may be symptomatic, have a sort of low-grade pyrexia or intermittent symptoms. So if you see a peripherally sclerotic lucency within the distal diaphysis or the metadiaphysis of the bone, think about a Brodie's abscess. And again, if you're worried about this, MRI. What about this young man? He's a 14-year-old boy. He had back pain, and actually it was causing him to become progressively immobile. He was generally unwell, and we decided he needed some imaging. He had an X-ray of his pelvis, which showed some asymmetrical soft tissue swelling on that right side. You can see that this is a normal left side. You can see the fat planes, the muscle planes, whereas that they're lost on the right side. So there's something going on over that right side. And he went on to have MRI. And you can see on the MRI, there is extensive soft tissue edema. There's focal fluid collections. This is postgadolinium, and you can see pockets of fluid with lots of enhancing soft tissue. And this is pyomyositis. Pyomyositis typically affects young adults. So if you've got a teenager that's struggling to mobilize or not really, or pyrexial with non-specific groin or buttock pain, think about a pyomyositis. Typically caused by a Staph aureus, and we do tend to see it in the pelvic girdle and the proximal lower limb. Investigate with MRI, and if need be, we get an interventional radiologist to drain the collections. What about inflammation? I know there's a number of rheumatologists in the audience, so this is going to be your area of particular interest. Can we see X-ray, joint fusion on an X-ray? Yes, we can. The astute amongst you will see that this actually is an association with trauma, but I want to show this as an example of a joint effusion at the elbow. The anterior fat pad is elevated, the posterior fat pad is elevated. There is fluid in this joint. These are the fat pads. The fat pads sit on the joint capsule and are usually flat against the bone. The posterior fat pad is not visible because it sits within the olecranon fossa, but they sit on the capsule, and if the capsule is distended with something, they are lifted out and become very apparent on the X-ray. What else might you see? Well, we might see joint space narrowing. That may be evident on a plain film. You can see this is normal, but you've got joint space narrowing here. That's obviously something that occurs late in the course of the disease. You can see on the lateral view, you've got joint space narrowing and focal calcification adjacent to the joint. This is because of joint injection. Sometimes you see soft tissue calcification as a result of joint injection, but again, that's something that we see less of now. And unfortunately, we still do see children that seem to have resistant disease that end up with significant erosions, significant pathology. This is there's destruction of the talus, destruction of the distal tibia, there's subluxation. This is a very obviously abnormal joint as a result of an erosive arthropathy. What about on ultrasound? What can you see? Well, you can see joint effusion, so you can see fluid, you can see synovial thickening, you've got the opportunity to support Doppler and see increased vascularity, and you can see erosions. Much less common in pediatrics, but again, something to bear in mind when you're looking at when you're doing an ultrasound in a child with arthritis. This is normal. So this is the suprapatellar pouch. This is a long view of the knee. You can see I'm using a linear probe. This is the quadriceps tendon. This is the patella ossified center here. So you can see that bright margin. This is the unossified cartilage of the patella. And there's just fat in this suprapatellar space. This is the abnormal version. Here's your quadriceps tendon, patella, unossified cartilage. But this is synovial thickening with fluid. So low echogenicity fluid with thickened synovium all around in that suprapatellar pouch. You can see synovial thickening in any area, really. These are images of the foot, and with color flow, you can see really hyperemic, highly vascular synovium that is in keeping with an active inflammatory arthritis. We use MR, of course we do. It's helpful in looking for bone marrow edema, and it is helpful in sometimes assessing the extent of pathology. You can see here that there are focal erosions with joint space narrowing and edema on either side of the joint. You can see those changes on the other sequences, and again, marrow edema in these sites. We use T2W sequences that are really nice for looking at the cartilage. You can see that there's unossified cartilage here. That looks really nice. And this looks like fluid in the joint. The problem with the T2 sequences is it's often difficult to tell whether you are looking at fluid or synovial thickening. So we also do a T1W sequence. You can see here, this is low signal. There's possibly a bit of thickening. Is this synovium or fluid? And when you give gadolinium, you get a much better impression of the synovial thickening. The dark signal, the low signal is fluid, and you can see how extensive this is in all parts of the joint. It's extending into Hopper's fat pad in the center of the joint and into the popliteal fossa. The axial view, you can see how thickened it can be, and you can see why you might misinterpret this as fluid. Without the gadolinium, this would just be low signal. So you've got this thick synovium and small pockets of fluid. Unfortunately, imaging cannot distinguish between inflammatory and infective arthritis. And what we would always say is that the diagnostic test of choice is joint aspiration. So if you've got a child that presents with a single swollen joint with evidence of synovial thickening, effusion, hyperemia, then you would have to consider that this is infection or inflammation. And the only way to tell the difference is with joint aspiration. Doing an MR in these cases is not going to help you. It's still not going to tell you the difference between the two pathologies. So if you've got a child and you're not sure it's a new presentation, then they need to have a joint aspiration and washout. Send the fluid for microscopy and inflammatory markers if you can. This is a 4-year-old boy with a swollen knee, no history of trauma. He's otherwise well. And again, this is an example of this is the normal fat pad in the suprapatellar space. And this is what happens when fluid fills that space or synovial thickening fills that space. You lose this nice lucent fat. It gets replaced with soft tissue density stuff. You stop seeing the quadriceps tendon because you're now getting soft tissue against soft tissue, so you don't get that definition. So if you can't see the quadriceps tendon, consider that there is something in that suprapatellar pouch. This is what hyperemic synovium looks like. And in this child, we also had associated tendon sheath thickening. So you can see here, your tendon is a nice stripy structure, and this margin should be nice and clean. But this is very pathological. There's low echogenicity, lobulated margin to this tendon. And that's because there is fluid and synovial thickening around it. And when you put color on it, you get starting to see some high vascularity within these areas. And this is in keeping with tenosynovitis. And again, it's just important to know what is normal. So there shouldn't be anything sitting around those tendons. They should be nice and clean. Our next case is a 6-year-old girl with a new limp and a normal X-ray. She came up for ultrasound. This is what a hip joint effusion looks like. In terms of technique, it is really important. The area that you are looking at is the neck of the femur. I'm not interested really in what is going on up here. This is where the effusions pool. So you need to get a linear probe in the groin with the foot pointing upwards, and you're going to look at the line of the femoral neck. And what you're looking for is a change in the normal concavity of the soft tissues. They normally follow the margin of the femoral neck, but here you can see this low echogenicity fluid and some synovial thickening in this hip. Fortunately, you can compare with the left side. You can see on the left, this looks much more normal. You can see how it's following the convexity of the neck, but be cautious. It may be that you have two pathological hips, and just because they look the same doesn't mean they're both normal. So in terms of infection, reactive, of course, you can get a reactive arthritis. Children that get viral infections may get effusion in the joint. You can have an inflammatory arthritis. And the difficulty we've got is that we can't differentiate with imaging alone. So it's really important to have clinical correlation. It may be that clinically you've seen that there are 2 or 3 joints involved, which makes infection much less likely. And we have really essential MDT discussions on a weekly basis with the radiologists, the rheumatologists. We often have, we may have the infectious diseases consultants may join us. It's a multidisciplinary team approach to ensure that these children get the right care and we make the right diagnosis. And as I've said, if you're not sure, aspirate the fluid, see what's in there. So how do we image JIA? Well, we actually use all modalities, as you've seen, and we've used plain film, we use ultrasound, we use MRI, but you don't have to image. I'm very fortunate. I work with fantastic rheumatologists like Cameron. They are clinically really astute. They know what they're doing, and it may be enough that they can make that clinical diagnosis without any imaging. So don't image if you don't have to. It's not essential. I'm sure you know all of this. You don't need me to tell you the different categories of JIA, how you subset them. But fundamentally, these all have joint pathology. So that's really what, from a radiology point of view, I'm interested in. I want to look for the affected joints. I want to look for associated tendinopathy. Is there anything else that is going on that I can see on the imaging? Our next case is a 13-year-old girl with a swollen medial clavicle and raised inflammatory markers. She is otherwise well, and this is her plain film. And you can see on the right, she's got a very sclerotic medial clavicle. The left side looks normal. This looks quite significantly pathological. As it happens, this is a pretty pathognomonic feature of a certain condition, which we're going to come on to. But I'm not going to talk about it until we've looked at our next case. This was a child that came in with back pain, no signs, no pyrexia, otherwise well, but enough that it was felt appropriate to image her. Now, she started off with a plain film, and actually one of the recommendations in the UK is that children with back pain should have an MRI. Plain films are not much use, and that's partly because a normal plain film, they've still got back pain, so you need an MRI, and an abnormal plain film, you need an MRI to investigate it further. So we did an X-ray in this case, but actually MRI was the most appropriate investigation, and that's what we went on to. And you can see there is something in her upper thoracic spine. There's something very abnormal. She's got a focal kyphosis, and she seems to have lost a vertebral body. She went on to have CT to assess this further, and you can see she has got a very impressive collapse. But the adjacent intervertebral discs look okay, and the adjacent vertebra look okay. So this is not collapse because of infection. This is a vertebral planar. So the vertebral body has collapsed without affecting the adjacent structures. She also went on to have a whole body stir, and you can see on the whole body stir that she's got abnormal signals. So a whole body stir is a fat suppressed T2 sequence, and what it does is it suppresses marrow, bone marrow. You can see there's abnormal marrow signal in her right proximal femur as well. And you can see the abnormal signal in her vertebra on that right-sided sequence. What causes vertebral planar? It can be infection, although that's less common because the infection tends to be associated with involvement of the discs, malignancy. So if you've got a vertebral body that's been infiltrated with disease, it can collapse. Eosinophilic granuloma, so think about Langerhans cell histiocytosis, CRMO, or even trauma. So if you have local trauma, if you have a significant injury that causes vertebral compression, that can give you the impression of a vertebral planar. In this case, we're talking about CRMO, and when you go back to her whole body stir, these foci of marrow edema are typical of the changes we might see in CRMO. So what is CRMO? Well, C is for chronic, but it may present acutely and be short-lived. R is for relapsing, but it might be a single episode, so they may only come on one occasion. M is multifocal, except that it might not be. And O is osteomyelitis, except it's not associated with pyogenic infection or positive cultures. So quite rightly, it is now known as chronic non-bacterial osteomyelitis. So this is a non-bacterial possible infection, but certainly inflammation of the bone. It's an autoimmune disorder affecting the skeleton of children and adolescents. It typically presents with spinal involvement in about, well, not typically, but in about 30% of children, and it can give you a vertebral planar. Long bone lesions may be anywhere, metaphyseal, epiphyseal, physeal, may even be in the diaphyses. So location does not help you with this condition, but they're typically multifocal. And how do we use MRI and CNO? Well, the idea with a whole body MR is that you get the maximum body coverage in the shortest possible time. Remember that you're dealing with children, so it's often difficult to, you want to get as much information as possible in as short a time as possible. You want them to be able to go in the scanner, have their study, and come out with a diagnosis. We do it as a coronal stir, so a coronal fat suppressed T2 sequence. There is a recommendation that if you can, it might be helpful to have an additional sagittal sequence, at least one sagittal sequence to look at the spine. And then there is another conversation about whether or not we should be doing an additional T1. So that all depends on your capacity and how good the children are. We are under huge stress in terms of imaging children at Alder Hey on MRI. So our capacity is limited, and doing a whole body T1 on every child would be a real struggle. So what we do is we do the whole body stir, and then we focus to areas of pathology if need be. But there are centres that do a whole body stir and a whole body T1 because they want to look at the marrow in a bit more detail. So it is quite good for problem solving. And if the signal is high on the T1, then again, that you'd have to think about other diagnoses. Do we use diffusion? Not routinely. So it's difficult to know what is normal. We tend not to use whole body diffusion sequences in CNO because we don't know what they should look like. But it may be something that comes in the future. What about this little girl? She's 6, she can't get out of bed, she's not going to school, she's weak, she's got reduced power. She came up to see us and we did an MRI. And this was the study that we saw. Now, this for me is a really good example of why we have to know what is normal. This is symmetrical. You can see the signal abnormality of the muscles looks the same on both sides. The bone marrow looks the same on both sides. There's fluid in the urine in the bladder, which is what this signal is here. Both hips, there's not really anything in the hips. But if you don't know that this is what a fat suppressed T2 sequence is supposed to look like, you don't know that this is pathological. So it's symmetrical, it's bilateral, but it is pathological. And this is myositis. This is inflammatory change within the muscles, and it's very diffuse. So you can be misled by symmetry. So just be cautious that just because both sides look the same doesn't mean that they're both normal. And clinically, the child may have a rash, they may have joint pathology. They're typically girls more than boys, but the MR appearances are diagnostic, and you only need the fat suppressed T2. Don't need any other sequences. You don't need gadolinium. You don't really need a T1. You just need the stir sequence. That will give you your diagnosis. What about metabolic disorders? This was I've just realized that I've numbered a lot of these as case 8. There seem to be a lot of case 8s, but they're not. They're all different cases. This is an 18-month-old or just over 18 months old, not walking, pulling to stand, but not cruising, and doesn't really want to weight bear. The baby was born here, but mum is Ghanaian. And clinically, she's got a swollen wrist. Let's start with a plain film. It's the most useful tool, as I say. I really like plain films. And actually, on this, In this child, we have got the diagnosis. You can see why her wrist is swollen. She's got cupped, frayed, splayed metaphyses. This is typical rickets. What is that? It's a vitamin D deficiency. We can see it in prematurity with poor nutrition or lack of sun exposure, and you get this typical cupping, fraying, and splaying of the metaphyses. And then in children that are mobilizing, you may then get a bowing of the long bones. What about this child? 12 months old with quite a complex background and an abnormal head. Now, there's a CT scan that I'm hoping you'll be able to see. And as you scroll through, you can see that the diploic space is markedly increased. This skull vault is very thickened. You're not surprised this child's got a very abnormal head. As you come up towards the fontanelle, you can see what's happening. You've got these very thick skull bones. This is significantly pathological. What about the rest of her? She's got slightly square looking bones. And when you look at her wrist, you can see she's got some periosteal reaction and what looks like a little bit of erosive disease. This is not normal. She's got slightly tubular looking loss of the normal tubulation of the bone. They're slightly undertubulated, so they're looking all very flat. And what's she got? She's got hyperparathyroidism. And it gives you that subperiosteal new bone formation and subchondral resorption. You can get osteopenia, you can get acroosteolysis, so resorption of the phalanges, and that rugged jersey spine where you get effectively a stripy picture to the vertebral body, so dense end plates and lucent mid portion. What about congenital disorders? I'm going to show you a few examples of some skeletal dysplasias. Children with skeletal dysplasia present with short stature. So if you're not short, the chances are that the pathology you're seeing is not a skeletal dysplasia. And these cause, can affect the epiphyses, the metaphyses, the diaphyses, the spine, or all of the above. In terms of description of shortening, if the proximal part of the limb is short, that would be rhizomelic shortening. If it's the middle part of the limb, it's mesomelic shortening. And if it's the hands, that would be acromelic shortening. And if all portions, so proximal, mid, and distal portions are affected, that's micromelic. I put this in because we talk about wormian bones an awful lot in pediatrics. And it's important that everybody recognizes them. So you can see, this is a skull x-ray, but you will see the same pattern if you do a CT and reformat it as a volume. Multiple intrasutural bones. It gives you a crazy paving appearance. In terms of numbers, the suggestion is that up to 10 is normal and more than 10 is pathological. Children with syndromes and disorders tend to have uncountable wormian bones. But the standard is that 10 is pathological. We use a mnemonic that is pork chops, P being pycnodysostiosis, O is osteogenesis imperfecta, R is rickets, K is kinky hair syndrome, and these are all things that cause wormian bones in the skull. Cleidocranial dysostiosis, hypothyroidism, otopalatal digital syndrome, primary acroosteolysis, so that's Hadju-Cheney syndrome, and the last one is Down syndrome. So if you see wormian bone, consider that it may be one of these diagnoses. What about this? These features are pretty pathognomonic of a certain condition. You've got sloping metaphyses, you've got a trident acetabular, so you can see this very prominent spur, probably a spur. You've got the metacarpals are all pretty much the same length, so it gives you a trident hand. And you've got scalloping of the vertebral bodies. This is achondroplasia. So if you see these features, if you have a pelvic x-ray that looks like this, then achondroplasia should be top of your list. What about this? This is a newborn. You can see long bones are very crumpled. There's bowing, there's beading of the ribs. This is a fetal X-ray. This is an older child with modeling deformity of the limbs. You can see here on this X-ray, there's a deformity. This is osteogenesis imperfecta. You can see the flattening of the vertebral bodies because of multiple compression fractures. At OI. This is type 2 because of the severity. Most children don't survive, but if you have, and again, this requires very careful handling. So it's one of the few conditions where we might do a babygram rather than a skeletal survey to avoid handling the child. This is a spot diagnosis. Apologies for the writing in the middle of the film. Remember to not miss what isn't there. It's very easy to miss what isn't there, and this child doesn't have clavicles. Pelvic X-ray shows horizontally placed femoral necks. This child has cleidocranial dysostosis, and you may remember, as I said earlier, it's associated with wormy bones in the skull. So you've had a bit of a whistle-stop tour through musculoskeletal imaging. What I want to make sure that you go away with is that all imaging modalities have a role. Get to know your radiologist. They are there to help you. They will support you. They will help you make diagnoses. They will help you care for your children. The MDT discussions are invaluable. And if you don't have an MDT, then I would suggest that you start one, because the more the people that you talk about cases with, the more you learn, the better a clinician and radiologist you might be. And if in doubt, I would always say, ask for help. That is my email address. If you need advice or if you need something, please don't hesitate to get in touch with me. Cameron is an excellent rheumatologist, so ask him. He will be able to guide you. As I say, if you've got radiologists that need some support, then please let them know. I'm happy to try and. So thank you. If there are any questions, please feel free to email me. There's my I'll be able to get that. Thank you very much. And please enjoy the rest of the webinar. I'm sure it will be excellent. Have a good day.
Thank you very much, Dr. Karan, for this very helpful talk. So I think we are now moving on to our Q&A session.
Good morning.
So,
my name's Karen Landis. I'm a consultant pediatric radiologist.
So rather than everybody talking regarding the Q&A, I think it would be a lot easier if you can type in the question and I can speak on from this side, and Dr. Kamran and myself will try to answer those questions. So the forum is open for Q&A, please.
Host, you can
So we are still waiting for any questions. So just one comment while we're waiting for questions to arrive. Dr. Kamran mentioned in his presentation regarding biologics. So regarding what my experience so far, of course, working here is that the patients, of course, they respond very, very well, or rather tolerate more than adults as regards methotrexate. So this is surprising. I always think that probably the kids might not be able to tolerate methotrexate, but what I've seen is that probably they tolerate better methotrexate than the adults do. But again, when we come to biologic, for example, I usually have a very low threshold prescribing biologics for our pediatric population, just because the time is the key rather than of course, we rheumatologists will love steroids. We start with the steroids, and mostly a lot of times is the last one that we get rid from. But again, in the kids, when it comes to I'm always very much anxious and worried and scared regarding the steroid use in the pediatrics for various reasons. And most of commonly is the AVN, and of course the growth being the stunted because of the steroid use. So that's why I would have a low threshold of introducing biologics in these. And a very recent study rather has shown, because we know the for rheumatologists, the achieving remission is of course the gold standard, but the best of all is not to achieve remission, but to achieve remission of drugs. And that is probably the best standard, the best success for a rheumatologist. So very recent study has shown that when it comes to pediatric population, for example, if the biologics are introduced within 2 years of the symptom onset, that the 20% of the patient would be eventually off all the drugs, means they would be achieved remission of drugs, 20%. But if that biologic introduction delay is from 2 to 5 years, then this success is halved, means only 10% will be able to achieve remission of drugs. But if there is a delay of more than 5 years of introducing biologic, this eventually, unfortunately, only 5% will be able to achieve remission eventually of drugs. So it means the biologic introduction is very, very important. But as Dr. Kamran said, of course, these are sensitive drugs. And of course, they can be associated with infection and all this. So in the right settings and the right hands, these are wonderful drugs. So I think there are some questions coming. We'll start from the first one. Again, what are the indications of intra-articular injections? Dr. Kamran, do you want to answer that, please?
Yeah, thank you, Dr. Haroon. Can you hear me well?
Yes, please.
It's not echoing. Yeah,
Thank you.
So indication, intra-articular steroid injection is the right and the treatment for oligoarthritis. So any patient who presents with less than with 4 or less joints, that's the standard treatment for them. So that's one indication. And obviously, joints that doesn't respond to systemic intravenous steroids will need joint injection. And then time to time, as have flare-ups, they will get joint injections.
Thank you, Dr. Kamran. The next question is, I'm sure you absolutely love to answer. And that is what is the current standard treatment for CRMO?
I think it's very difficult to answer this question as a comment. We should probably have a separate lecture. I'm one of the leads for non-bacterial osteomyelitis and part of international consortium. So it's not too much about starting treatment. First diagnosing right patients. So I think in the patients diagnosed in Pakistan, for them to have bone biopsy to confirm the diagnosis rather than based on whole body MRI scan, because there is no such expertise as Karen Landis, people like Karen Landis has. So it'll be very dangerous to diagnose CRMO based on a whole body MRI scan reported by an adult radiologist who has some training in pediatrics. So assuming that someone has the right diagnosis, then first line treatment is anti-inflammatory medication such as Brufen, Naproxen, diclofenac. Second line treatments are bisphosphonates such as pomidronate or zoledronate. Again, it's too long and we don't have that much time to explain how we give it and how often we give it. Patients with CRMO who have associated arthritis, they usually go on to get treatment with methotrexate or sulfasalazine or ENF such as adalimumab.
Right. The next question is, I think they're talking about erosive ankle arthritis, that how can we stabilize that joint? I think they might be talking about one of the x-rays, one of the study you mentioned.
Yeah. So before that, I think there was another question, spontaneous emission is possible in JIA. unlikely, but we have seen patients responding. Oligoarthritis can respond just to anti-inflammatory medication, so high-dose naproxen or brufen in oligoarthritis can induce remission, but then you have to monitor them long term. The next question is about the process of erosive ankle arthritis. So it's a step behind erosive ankle arthritis. So patients who have difficult joint disease that doesn't respond to number of treatments, and they're heading towards erosive disease, which eventually to joint replacement in long term. So that surgical procedure, arthrodesis, is to prevent that damage, because we can't, children has to grow, so they're different from adults, so we can't stop the process of growing. And if we don't do anything at that point, then the bones will get erosive and destructed, and there's no other option. By doing procedures like this, the joint gets preserved for a while, so it's a temporary process that can buy you 2 or 3 years, make your patient pain-free or in less pain, and no direct contact will cause less inflammation. And in 3 years, who knows, there are newer medications available, disease can get under control, and at least child will have a skeleton.
Right. The next one is how can we decide about biologic agents in case of chronic arthritis with deformities? There is no active arthritis.
So if you are presented with a undiagnosed new patient of arthritis who never had any treatment, then I would treat them accordingly. That I would treat them with steroids, joint injections, methotrexate, wait for 12 weeks for methotrexate to work or fail, and if not, then proceed with biologic. Just because they have deformities, there's no point to just jump on biologic straight away. But if these patients have axial arthropathy, for example, and situs-related arthritis and ankylosing spondylitis, then there is room to start on biologics and methotrexate straight away, because they respond very well to combination of these treatments. If this is a chronic patient who has deformities, then obviously it means that the previous treatment didn't work, and they had somehow untreated arthritis or treated arthritis. Then again, escalation of treatment is indicated.
Yes, I think it's important to discuss this as well, because we are talking about the inactive disease. So first of all, for rheumatologists, of course, the most important thing is to define whether this patient has gone active disease, because of course, naturally, there are a lot of different reasons for pain. For example, the pain could be secondary. Of course, this we are talking about in this particular case is somebody already having deformities. So this could be a secondary osteoarthritis. And also there could be long-standing disease, some myofascial component as well, which we see in our adult patients quite often. So it's very important to establish whether there's an active disease or not. If we establish that it's an inactive disease, naturally increasing the immunosuppressive drugs doesn't make sense.
Yeah, absolutely. So it's only in the context of patients who have active disease. So to establish that they have active disease, you have benefit of imaging. So imaging should help you if they have active inflammation or not. If there is inactive on the scan, for those who presented very first time with long-standing chronic illness, in pediatric population, I think there is still room to treat them with at least DMARDs, because I would be very surprised if I see a child with chronic arthritis never been treated and now has inactive disease.
The next question is, of course, is that a patient with the CRMO, do they present with fever?
Yes, they can present with fever. So there is, in the traditionally people thought of CRMO as a relatively non-inflammatory presentation, usually pain for many weeks to months. But there is now a new entity described as highly inflammatory CRMO patients. In fact, I published 2 papers on that as well. And so they can present as pyrexia of unknown origin, but then you have to exclude all other possibilities. So exclude bacterial infections, exclude malignancies, and possibilities. So those patients who have very high inflammatory markers and fever will definitely need a bone biopsy to confirm, to exclude all other possibilities. I think there are a few questions that got missed. One was that why don't we give folic acid and day of methotrexate? Answer is very simple, because methotrexate is anti-folate. If you then it won't work. I did. There was another question. Do you suggest IV steroids? That's the standard treatment. For poly-GIA patients, and they get pulse steroids, which is another way of calling it IV steroids. I explained it in detail in my presentation. Causes of CRMO and CNO are similar to other autoinflammatory. So these are response of our immune system, and mostly patients who get CRMO usually have a tendency, and then something activates their immune system. But these are autoinflammatory. CRMO is a autoinflammatory condition. It's not an autoimmune condition. So most of the times, doesn't have any antibody positive. Sometimes a previous infection can trigger it.
Great. So the next question also is about, they're talking about oligo-GIA. If somebody with oligo-GIA is not responding to methotrexate, even the injectable form of methotrexate, and also weekly etanercept, I think this is talking about the proper dose. Should they switch to twice weekly etanercept? There's no mentioning of the dose as such. I think probably there might be.
Okay, I think people are writing half question and then somehow pressing the enter button, then writing another half question. So oligo-GIA does not need systemic treatment. So you need to understand what systemic treatment means. So methotrexate or systemic steroids or intravenous steroids are systemic treatments. Oligo-GIA is only requires intra-articular steroid injection. However, if you have a patient who has persistent oligo-GIA can be the patient has knee inflammation once every 2 or 3 years. That patient doesn't require systemic treatment. But if patient has 3 or more episodes of joint inflammation within 1 year, or 2 or more episodes of ankle inflammation within 1 year, or more than 2 episodes of in 3 years, because ankle and wrist are complicated joints, then they should go on systemic treatment, which is methotrexate initially, and then if that doesn't respond, then they can go on biologic. Otherwise, as a rule of thumb, oligo-GIA does not require systemic treatment.
Great. Just a question from myself. In adult population, at least we do a lot of switching of biologics. For example, if one particular biologic is not working, we usually switch class to a different one, or sometimes even with the TNF, with the, for example, other than the receptor regards, we know etanercept, we change to monoclonal antibodies. How your experience of switching biologics?
This is this is very similar to pediatric population. So when we start biologic, we usually start with etanercept because etanercept longest used and has the longest data. We tend weekly because we think that in flare-ups and acute presentation it works well. If a patient not responding to etanercept, then we switch to other anti-TNF such as adalimumab or tocilizumab. Sometimes infliximab. Those patients who don't respond to anti-TNF, we switch them to IL blocker, mostly tocilizumab or abatacept. And sometimes we go back to etanercept after trying a couple of other biologics. We retry etanercept. So it's hit and miss. In some patients it works very well. In some patient only one biologic patient do need. You know it very well, and I hope most of the audience know that biologics cause modulation of immune system, and they produce by using same biologic for a long time, there is risk of producing antibodies against that biologic, and that sometimes can get nullified by using small dose methotrexate. And also if we switch to a different class, then the antibody the previous class will not be a cause of concern.
I think the next question you have answered already. The question is that can you repeat intra-articular steroids for every time oligoarthritis patient gets a relapse? I think probably what you mentioned, it depends on how many times in a year that particular patient is relapsing. Of course, if it is happening quite often, every few weeks, then actually you should be thinking rather than injecting every single time, every few weeks. If I'm right, Dr. Kamran?
Yeah, so again, if we end up injecting same joint or 3 episodes of joint injections within 1 year, this is just body telling us that localized treatment is not working and we need to escalate to systemic treatment. The reason that we say 2 for ankle and wrist, because they are closed joints and very complicated. So we have seen that leaving wrist and ankle for long usually causes complication.
The next question I think is important. If a child comes with a stiff wrist and ankles along with other small joints, so there's stiffness of the different joints. He's already a diagnosed case of polyarticle GIA and has been on methotrexate. Currently, this particular child's inflammatory markers are normal. So can we say that this patient does not need escalation of treatment based on inflammatory markers and should be discussing about the physiotherapy and so on? Or
so sorry, go on.
Or I'm just summarizing the question for everybody because it's an important question. Is based on the symptoms, I think probably if I'm taking this question right. So based on the inflammatory markers, what they're asking is, can we exclude this patient being having an active disease and looking for physiotherapy and different painkillers, for example?
So I think it's the question that you have already given a beautiful. So we need to define if the disease is active or not. Inflammatory markers are not good way of defining if disease is active or not. Especially in a diagnosed patient, inflammatory markers can be normal because they will be masked by the treatment patient is already on. So I'm assuming if you have a patient who has poly-GIA, the patient will be on some sort of systemic treatment. So you need to define that stiffness is because of inflammation or because of mechanical reasons. If it's because of inflammation, because inflammation is visible on MRI or ultrasound scan, then escalation of treatment and with either joint injections or switching from adjusting the dose of DMARDs as DMARD biologic. But if there's no inflammation, then physiotherapy. In case of inflammation, you still need physiotherapy to help this patient to achieve full strength.
There's a next question is a little bit, we need a bit of time to elaborate, but they're talking, if you can summarize in a few sentences, they're asking about the differences between autoimmune and autoinflammatory.
So I think I mentioned in my first lecture, so these are years ago, all these conditions that we deal in rheumatology were labeled as autoimmune conditions. Then we realized that not all autoimmune conditions, and a lot of those are slightly different from there are 2 distinct groups within these conditions. So autoimmune conditions are those where problem is in the adaptive immunity alone. So these patients, so the conditions like inflammatory arthritis, diabetes, autoimmune thyroiditis, these are autoimmune conditions where you have a problem with the dysregulation of that section of immune system. While the autoinflammatory conditions are those where your innate immunity is unregulated. So these are conditions where that condition symptoms. So for example, Behçet's disease, so where you have mucocutaneous involvement, skin involvement, rashes, infections, arthritis, CRMO, where you have a whole body involvement, skin rashes, arthritis is also an autoinflammatory condition. Conditions like periodic fevers, chinka, NOMID, FMF, all these are autoinflammatory conditions. It's a little bit bigger topic than the scope of answering in a question answer session.
Absolutely.
We can do, maybe we can do a separate talk on differences in autoimmunity. In general, autoimmunity is when your adaptive immunity is impaired, and autoinflammatory when your innate immunity is dysregulated. So you will see the autoinflammatory patients can present from birth. So for example, Tinka syndrome, NOMID patients, they present from birth, because the problem with innate immunity can present from very early on in the age, and autoimmune conditions usually a little bit older age group.
I think it has been answered already, but I think it's important to just elaborate for everybody. They're asking how frequent can we give intra-articular injection in one particular joint, keeping in mind the risk of joint destruction or instable.
So bigger joints, I think it's not a huge problem like knees, hips, and shoulder, but I'll be very worried why that joint is requiring repeated injections. So either there is something wrong with the technique, or disease is uncontrolled. So usually when we do injections, we either do ultrasound guided or image intensifier, so we know exactly where the medicine is going. And if disease is uncontrolled, obviously it needs escalation. For I'm repeating same thing again for smaller joints such as fingers or toes or wrists, and we tend not to do more than 2 injections. And if we've done 2 injections, then we escalate treatment, move on to biologics or give IV or oral steroids to achieve remission control, rather than keep injecting them.
So the next. I think the next question is about poly-GIA, that if, for example, in Pakistan, of course, a lot of patients cannot afford biologics. So the question is, how can we escalate the treatment? I assume the patient has already been on the maximum dose of biologics and the NSAIDs. What could be the other option?
So if patient can't afford biologic, then you have other DMARDs that you can use. For example, sulfasalazine can be used alongside methotrexate. Hydroxychloroquine can be used. And I'm not, MMF CellCept is a very, very good medicine in general for inflammation, but it works very well in vasculitis and lupus and JDM. So it works very well for arthritis, but that's another option. I don't know if it's cheaper than biologic in Pakistan. I think there are lots of resources. One should always try to find a resource for the right treatment. So there are a number of charities, there are a number of people who can support Battlemal, and now you have biosimilars available. So maybe you can compromise on frequency. So rather than giving it every week, give it every 2 weeks, or rather than giving every 2 weeks, give it and keep methotrexate and high possible dose. So maybe a little bit compromise on frequency and dosing, but biologic would still be a better option if possible.
One other thing is that I've seen again in the sort of controlled sort of environment, adding methotrexate with the leflunomide is again very important in a controlled setting, because there's a very high risk. There's a very high risk again of hepatotoxicity if you combine methotrexate and leflunomide. So this, what I've seen again in our own settings, can be another option. But again, of course, the side effect, because there's a black box warning of combining these 2 drugs together regarding the hepatotoxicity risk. Dr. Kamran is absolutely right. So there's a lot of options available in Pakistan. There's a lot of charities who are absolutely happy to fund these young kids. If somebody's having, who's local enough, for example, in Fatima Memorial Hospital, we're absolutely happy that these young kids are referred to us if they need some help as regards the funding for biologics or anything.
And this is absolutely right. And this is where networking is very important. So have this fear that I will ask someone. At the end of the day, you want patient to get better. So keep patient under your care, but maybe link with the centers who have availability of these medications. And then you can provide local care to that patient, and they can come to Lahore or come to Karachi to get these medications. I know there's a lot of government hospitals are now providing biologics through Battlemal. And I like to think that with the help of universal health card, and that money can be used in right hands with to right people. That money can be used for medications like biologic.
Somebody mentioned about the SAS program. Unfortunately, Sehat Sahulat programs and all this, they are not funding biologics. So they're not, at least in Punjab, they're not. I'm not sure about the other provinces. We tried, but in last week or 2 weeks earlier, we heard there were earlier talks that they might be, but as we speak, and at least in Punjab, they're not funding biologics or these arthritis drugs. But at least we need to keep trying, of course. So I think we are out of time already. I promised to Kamran that we'll try to finish it by 3 o'clock. So thank you very much, Kamran, for being with us. I'll be requesting people, because of course, Dr. Karen has joined us as well. So at least we need to give her some feedback as well, that how much we have all learned from this particular session. So keeping in mind that, of course, she will not be able to understand mashallah, jazakallah and all this. So if people can send some feedback so that we can forward it to her. So we'll be grateful. We'll try with the help of Dr. Kamran. We'll get some session again from her as well during the time. So at least send us some feedback that what it had helped this particular session from herself and overall this session. So we can pass on to her as well. Of course, it's always helpful to know that, again, she has been with us for about an hour or so, that at least her time was helpful for us as a community in the whole country, because we don't have any pediatric radiologists in the whole country. So I think it's very helpful to send her some feedback of her time being, how useful it was for us as learners.
And I just want to take this opportunity to thank you, especially Dr. Haroon, because you have been working on this tirelessly, and I know how difficult it is. I also want to thank all the audience for being part, because if nobody's listening, then we wouldn't be doing this. Most Karen, who's a lovely colleague, and when I asked her, she immediately replied that she's happy to help. Not to point finger to anyone, but I actually contacted another radiologist who was of Pakistani origin first, but had other commitments and declined my offer to help. And when I asked Karen, she was delighted to come and help. And she's a lot more busy than any other radiologist, because she does a lot of out of hospital. So huge thank you to her and to all of you. And hopefully we'll meet again by end of March.
Great. Thank you so much, Dr. Kamran. Thank you so much. We're much obliged for all your support. And now I think we can call this off. So thank you very much, everyone. Assalamu alaikum, and look after yourselves.
Thank you. Bye-bye.
Officer, thank you very much.
Thank you.